And as you will know that we have different imaging modalities, including the barium studies, the endoscopic ultrasound, CT, MRI, and the PET scan. Esophageal tumors are either benign or malignant. The benign lesions include leiomyoma, vascular polyps, granular tumor, and the benign form of GIST, while the malignant lesions, by far, the most common is the squamous cell carcinoma, then adenocarcinoma, lymphoma, the carcinosarcoma, malignant GIST, neuroendocrine tumors, and esophageal metastases. As you all know that endoscopic ultrasound is one of the sensitive modalities, especially in the early stages of esophageal malignant lesions, since it is able to see the esophageal layers. So it's very helpful in the assessment of early stages of esophageal cancer, and also it can differentiate between the normal lymph nodes and nodes containing metastases, and it can help in the selection of the line of treatment. Benign neoplasms represents about 20% of esophageal tumors at autopsy, while 1% of these tumors come to the clinical attention, and they include, as I have said, these types of the tumor. But the first is the most common one is leiomyoma, which represents about it is usually the commonest esophageal benign neoplasm, but is far less common seen in the clinical practice compared to esophageal cancer. Most of the leiomyomas are in the range of 3 centimeters, and they usually grow in the wall with exophytic extension into the adjacent area. Leiomyomas may contain areas of calcium, and they do not usually show central necrosis or degenerative changes or ulcerations. Then most of the leiomyomas may be asymptomatic. If they are large, they may cause dysphagia, and they are typically seen in young males, with the lesions are usually solitary and maybe multiple in about 33% of cases. You see in the barium swallow in this mural lesion, which has an extremely smooth surface, and it has an exophytic growth. It indents the esophageal lumen, and it may contain calcium and rarely ulcerate or show central necrosis by CT. And you can see the lesion in the posterior mediastinum, and you see the matrix calcification. And as you all know that these tumors usually show negative results by PET scan, since they have low metabolic activity. By endoscopic ultrasound and by CT, one of the helpful diagnostic criteria is to see the tumor in the wall of the esophagus with compressed eccentric esophageal lumen, sometimes contain air or maybe some of the orally administered contrast material. If you look to the esophagus from one side, you can see expansion of the lumen, while if you look on the opposite side, then you see reduction of the lumen with exophytic extension of the tumor. But by CT, you see that one of the characteristic criteria of leiomyoma is the compression of the esophageal lumen at the edge of the tumor. And this is a good example by barium osophagography, and by CT, you see the stretching of the air-containing esophageal lumen on the surface of the tumor. And this is a huge leiomyoma showing significant compression of the esophageal lumen, which is seen here stretched over the outer surface of the mass. The differential diagnosis of leiomyoma include esophageal duplication cyst, which usually appear as a cystic lesion on CT, and of course on ultrasound as well. Granular tumors, which are considered rare compared to leiomyoma, and also they are usually multiple. The benign type of GIST is a small lesion, and if it is large, it may show central necrosis and ulceration. Also including in the differential diagnosis the lymphoma and the metastasis. The second benign lesion in the esophagus is the fibrovascular polyp, which is composed of fibrous tissue, fat, and some of the blood vessels. This lesion is usually seen in the cervical esophagus, and it may grow for a large size along the esophageal lumen. One of the characteristic symptoms of this particular lesion is the regurgitation of the polyp from the mouth. And because of this regurgitation, surgical excision should be performed because of to avoid the risk of sudden death. On CT, because of the fat content, and you see the tumor is of hypodense hypodense matrix, it may contain calcium. It starts high up in the esophagus and extends for a good segment of esophageal lumen. And this is by barium oesophageography, and you can see the filling defect, which is an extremely smooth outline extending high up in the esophagus down approximately reaching the mid-esophageal segment. Because of the fat content, these tumors will appear hypodense on CT images. They will be echogenic on ultrasound. They show high signal on T1 weighted images and low signal on fat suppressed MR imaging. Calcium is of course detected by CT more better than MRI. And this is an appearance of a fibrovascular polyp showing the hypodense texture and maybe some foci of calcification. Granular tumor is a rare tumor arising from the Schwann cells, and these tumors are commonly seen in the skin, the subcutaneous tissue, and the tongue, but may also seen in the GIT, and 1/3 of these tumors of GIT origin are seen in the esophagus. The tumors are usually small, they have smooth surface, and they may be multiple, and about 1 to 3% may turn malignant. This is an example by endoscopic ultrasound and by barium oesophageography of granular tumors. You see two lesions with a smooth surface, and they are small. Multiplicity is relatively common, occurring in about 10% of the cases. And by endoscopic ultrasound, the lesion may mimic the leiomyoma. This is endoscopic ultrasound showing the appearance of the tumor, which is arising from the mucosal surface of the esophagus. And we came to the malignant lesions, and on top is the esophageal cancer. And approximately 80% of esophageal neoplasms are malignant. 90% of these malignant lesions are the squamous cell carcinoma, and less frequently the adenocarcinoma. And these are the risk factors, including tobacco and alcohol. And the main presentation is by dysphagia. In cancer esophagus is relatively uncommon. It represents 1% of all cancers, 4 to 10% of GI malignancies, relatively more common in males compared to females. These are the risk factors, and I stress on the alcohol and tobacco, of course, beside many other lesions. And squamous cell carcinoma represents about up to 95%. Adenocarcinoma is in the range of 4 to 19%, and is usually arising on top of the Barrett esophagus and occurring lower down in the esophagus, as reflux esophagitis is one of the predisposing factors. Of course, there are many types of esophageal malignancies, and the two most common types are those, the squamous cell and adenocarcinoma. Then on the chest radiograph, sometimes you can, if the tumor is large and it displays the normal anatomic lines in the mediastinum, then there may be widening of the zygoesophageal recess, widening of the mediastinum, tracheal deviation, posterior tracheal indentation, retrocardiac mass, air fluid level in the esophagus proximal to the tumor, and the lesion may extend into the stomach, as seen here by the gastric air bubble. Sometimes we see aspiration pneumonia due to obstruction, and maybe tracheoesophageal fistula. The appearances of esophageal cancer on barium oesophageography include many types: the polypoid, the varicoid, infiltrative, ulcerative, and the submucosal superficial spread, the stricture, or the pseudoachalasia type if it occurs in the distal part of the esophagus. Then the main values of CT in the evaluation of esophageal cancer is to evaluate the invasion of the mediastinum and to detect distant metastases. Also can show complications of esophageal obstruction and the development of tracheoesophageal fistula. Metastases commonly go to the liver, but maybe to the lung and bones. And the CT, of course, as also MRI, are somewhat less sensitive for detection of the lymph nodes. And also, endoscopic ultrasound has its major advantage in showing the esophageal the esophageal wall in details, including the hyper-echogenic mucosal surface, and then the hypoechoic mucosa itself, then the hyperechoic submucosa, then the hypoechoic muscularis propria, and finally the adventitia, which is also hyperechoic. And this is the T staging of esophageal cancer. Of course, the T1, T2, and T3 can be detected by endoscopic ultrasound, but if the lesion has invaded beyond the esophageal lumen, then you can see this by CT for CT, of course, if it extended outside the wall of the esophagus. And the staging of nodal metastases depends on the number of lymph nodes in the region of the involved segment. N1 means 1 to 2 regional nodes, N2 3 to 6 regional nodes, and N3 more than 7 regional nodes. And the M1, of course, is the detection of distant metastases. Then this is a presentation of a very early esophageal cancer affecting the mucosa by endoscopic ultrasound, and this was a case of Barrett esophagus with esophageal adenocarcinoma. This arrow points to one of the affected lymph nodes in the region of the esophageal tumor. And we should know that sometimes the stricture secondary to malignancy may not allow the passage of the echo endoscope in a good percentage of cases. And this is what we call the pseudoachalasia. This is the achalasia. You see the tapering, smooth narrowing of the distal esophagus. But here you see the irregularity, the mucosal destruction, and the proximal shouldering, which are criteria of suspicious of malignancy. And of course, these cases warrant further evaluation by endoscope. By CT, esophageal carcinoma will show a lesion which is circumferentially involving the esophageal wall. The esophageal lumen may be at the center of the mass and may be eccentric, but it is not at the periphery of the mass like in the cases of leiomyoma, for example. Then CT also can show the invasion of the surrounding structures, can assess the extension to the adjacent mediastinum, can see mediastinal lymphadenopathy, and of course pulmonary metastatic deposits. And this is the case of esophageal carcinoma. You see the esophageal lumen, and you see the mass circumferentially surrounding the wall, and the lumen is more or less eccentric. And this is another case of esophageal cancer involving the distal part of the esophagus, and the esophageal lumen indicated by the orally administered contrast material is seen eccentric within the tumor mass. Of course, the esophageal cancer and its metastases will show uptake by the PET-CT, and this is one of the values of PET-CT. In such cases, it can or may prevent unnecessary surgery by detecting metastases that were not seen with conventional imaging modalities. Then esophageal adenocarcinoma, as I have said, occurs on the top of the Barrett esophagus, which represents mucosal dysplasia of the distal part of the esophagus secondary to chronic gastrointestinal reflux disease. Hence, the appearance of the lesion will be in the distal part of the esophagus, and it was previously thought to be of gastric origin that has invaded the distal part of the esophagus. But adenocarcinoma is a well-known entity of esophageal cancer. It's predominantly affecting the lower segment of the esophagus and may extend into the stomach. The patients usually had this history of hiatus hernia and chronic gastroesophageal reflux disease. And esophageal lymphoma is considered rare, and as it represents about 1% or less than 1% of all GIT lymphomas. And this may occur primarily in the esophagus or may result by direct extension from the stomach or from affected mediastinal lymph nodes by lymphoma. The clinical presentation is mainly by dysphagia, and the most common type of esophageal lymphoma is the large B-cell lymphoma. The lymphoma is characteristically involves a good segment of the esophagus. It has a predominantly submucosal spread, but many times the appearance of lymphoma is relatively non-specific, and it cannot be easily differentiated from the carcinoma of the esophagus. In this particular example, you see a good segment of the upper esophagus that has been infiltrated by a mass causing some filling defect and mural irregularities, and this mass was seen by CT. And you see the esophageal lumen containing some of the orally administered contrast material, as well as the tumor mass circumferentially surrounding the esophageal lumen. And lymphoma, of course, will show some significant uptake on PET scan imaging. This is one of the let us say diagnostic forms of submucosal esophageal infiltration, and is not of course specific for lymphoma, but if you see a good segment and submucosal infiltration, one may suspect this diagnosis. And here is a lymphoma involving the distal part of the esophagus as well as the gastric fundus, with significant bulboid mucosal thickening and irregularities of the wall. And this is also another example of esophageal lymphoma involving a very large segment of the esophagus with mucosal and mural irregularities. And this is the appearance by CT scan. You can see the esophagus within the central part of the mass. And this is another case of esophageal lymphoma showing concentric involvement of the esophageal wall. This spindle cell sarcoma or spindle cell carcinoma is a biphasic malignancy with a squamous content and sarcomatous component. This lesion is considered rare and usually affects the distal part of the esophagus. It may appear as a bulboid mass in the middle or in the distal third of the esophagus, and may be mistaken for a squamous cell carcinoma, sometimes for lymphoma, but it is not mistaken for fibrovascular polyp, for example, because the polyp starts in the cervical esophagus and it should have a very smooth contour. The neuroendocrine tumors are rare in the esophagus, represents about 1%. They are aggressive neoplasms, and 70% of the patients may have metastasis at the time of the presentation. The tumors usually affect the distal part of the esophagus, and many times you see hypervascularity of the primary tumor as well as the metastatic deposits. Other hypervascular neoplasms in the GI include the guest hypervascular metastasis, Kaposi sarcoma, paraganglioma, and the solitary fibrous tumor. This is a case of benign guest tumor in the esophagus. It can simulate exactly the appearance of leiomyoma, being of relative hypodense texture. It stretches the esophageal lumen along the contour of the esophagus. But guest tumor may contain calcium, but leiomyoma do not show areas of necrosis, while guest, if it is larger, it may show ulceration and necrosis. Finally, the esophageal metastatic deposits are discovered at autopsy in about 3% of patients with primary malignancies, and metastasis may occur by direct extension from mediastinal structures or from mediastinal nodes, and can also occur by hematogenous spread to the esophagus. They usually appear as a short or long stricture, and even sometimes they can appear as a submucosal mass. The clue for diagnosis is the presence of primary malignancy, which can support the diagnosis of metastatic deposit. Thank you very much.